Uh, I would be dealing with the I would be talking to updates in the management of breast cancer as per ESTRO guidelines pertaining to this thing. May I have my first slide? Just to give a brief background, we all know that breast cancer is a global disease which has high incidence and thereby requiring high attention both clinicians and and of course research academicians. As per the recent World Census, Asia comprises the maximum number of cases of breast cancer, and of which India takes a major chunk. Next slide, please. With 7.8% share in incidence, India has relatively high mortality, which stands for about 13.9%. This is a global consensus, and we might underrepresent the actual numbers. We also need to understand that breast cancer is a systemic disease with high local regional failures. With such high numbers in both incidence and mortality, we need to strengthen our local regional treatment modality to enhance the outcomes. Next slide, please. Yes. ASTRO has come of series of consensus guidelines for different clinical scenarios, particularly addition, quality of radiation therapy. Next. Yes. I will be primarily focusing two major guidelines. Next. First one is the latest update on how to irradiate the whole breast, and number two is post-mastectomy radiotherapy, also known as PMRT. Next slide, please. Again, the ESTRO has also issued a series of guidelines in conjunction with ACROP and JEC groups, and these are these are primarily related to the technical aspect of addition of radiotherapy. It focused on contouring in different scenarios like intact breast, brachytherapy, and in cases where immediate reconstruction is done post-mastectomy, various techniques, and setup verification. ESTRO primarily focuses on the standardizing radiation treatment so that an improvement can be foreseen in the unidirectional manner. Next slide, please. They have primarily asked 5 questions pertaining to decision making of start, doses, and treatment volumes for intact breast. The data is primarily collected till mid-2016 and then analyzed. Click, please. Yes. And the ASTRO panel has assessed the data in terms of overall survival, disease-free survival, recurrence, acute and late toxicity, and of course the quality of life in these patients. Next slide. The initial task force was made in 2011. Similar questions were asked, which will be discussing that I will be discussing in next few slides. The major change in the recommendations lies in the strength of the evidence, which has increased now. The 2011 task force was initially made to probe in the new idea of hypofractionation in breast and formulated working guidelines for hypofractionation to be used in clinics. Next slide, please. This is the updated recommendation from ASTRO panel, which was published in 2018. It primarily focused on hypofractionation. For those who are not radiation oncologists, let me explain the hypofractionation. Hypofractionation means the treating the area intended with high dose per fraction with lesser number of fractions in total. thereby delivering similar radiological effect. Next slide, please. ASTRO panel, in fact, formed 5 basic questions and took a consensus on the available evidences. Question number 1 is pertaining to dose fractionation scheme in whole breast. Does this recommend fractionation change with different tumors or patient profile? Question number 2 was related to the tumor bed boost. And what are its indications? How to effectively irradiate the tumor bed? Next slide, please. Question number 3 was, when treating tumor bed, what fractionation is adequate, and in what sequence to the whole breast radiation should be employed? Question number 4 and 5 are related to the technical aspects of delivering radiotherapy. Next slide, please. As of 2018, the question hypofractionation for whole breast is undisputed. You can either treat with START protocol or with Wilhelm protocol in 15 or 16 fractions. This treatment protocol, if you see, is irrespective of the low axillary coverage. However, we need to cautious in patients who have heavily studded axilla, or where we intend to treat level 3 or SCF or IMC nodes. Even though small clinical studies have pointed out the safety of hypofractionation in regional nodal irradiation, the data is still lacking of level 1 recommendation or a stamp. However, the panel recommends the use of hypofractionation independent of grade, margins, hormonal status, age, histology, laterality, breast size, use of chemotherapy, and of course DCIS. As you know, and you can see here, the recommendation strength is strong. You can see recommendation strength is strong with high quality and 100% consensus on this statement. Next slide, please. Question number 2, which addresses the issue regarding the tumor boost. The indications are clear and have a strong recommendation for the panel. In cases of IDC, any of the following is mandatory, like age less than 50 years of age, high grade, positive margin, either focal or persistent. For DCIS, any one of these characteristics are mandatory, like age less than 50, high grade, close margin, or positive margin. Next slide, please. See the question number 3, the dose fractionation in cases of tumor bed boost is, it was on tumor bed boost. The absence of strong risk factors in cases where there is no strong risk factor is there, then sequential boost 10 gray 5 fractions was adequate. While in presence of strong risk factors, either sequential boost where the dose was 14 to 16 gray, or sequential boost where 12.5 gray in 5 fractions was recommended. In fact, we still do not have level 1 evidences of safety treated whole breast and boost simultaneously, and therefore the guidelines recommended treating them one after the other. However, newer data is coming up where incorporating boost simultaneously with whole breast is safe and feasible. Hopefully, with the upcoming trial results like Hypofractionation trial, we can change the level of recommendation. This trial is about to finish in 2023. Next slide, please. As I said, question 4 and 5 are technical questions. where the consensus lies with various checks and safeguards in treating breast, like maintaining dose homogeneity. Strict parameters are mentioned here. Other things like cardiac delineation and avoidance, setup reproducibility and image guidance, and of course to protect the normal tissues. Next slide, please. Yes, this is the difference between 2011 and 2018 ASTRO guidelines in a nutshell. ASTRO panel now strongly recommends hypofractionation irrespective of any age, any stage. Any stage. Here I want to highlight, I want to mention that as long as you don't need to treat high level of regional lymph node, any stage is recommended for hypofractionation. And of course, any chemotherapy is also comes in this category where hypofractionation is recommended. Next slide, please. This was the study conducted by UK group called FAST Trialist Group, and they included patients with node negative early breast cancer in women with age more than 50 years of age. And the primary endpoint here was in this study was the 2-year cosmesis. Next slide, please. Yes. The patients were divided into 3 groups. Next. Next. Yes. They are divided into 3 groups. First is 50 gray in 25 fractions. Second is 30 gray in 5 fractions. This was 1 fraction once a week. And third fractionation schedule was 28 gray, 28.5 gray in 5 fractions. Again, 1 fraction in 1 week. The endpoint was assessed via photographic appearance of breast at 2 years. Next slide, please. Even though 28.5 gray, next. Yes, even though 28.5 gray arm was comparable for 50 gray, the concept was never adopted in mainstream clinic as data presented only early cosmosis results and did not have any survival outcomes in this study. Plus, 1 fraction once a week was logistically viable as patient coming from very far and had to travel every week rather than completing or getting treatment in one go. Next slide, please. This is again the ongoing trials. Next slide. This is actually the fast forward trial and was initiated with the intent to assess the extreme hypofractionation, a treatment which will be completed by 1 week in comparison to 3 to 4 weeks. Patients were divided into again in 3 arms: 40 gray in 15 fractions, 27 gray in 5 fractions, and 26 gray in 5 fractions. At 5 years, IBTR was similar in 40 gray and 26 gray. With such promising results, the possibility of inclusion of such phase 3 data in guidelines is always there. However, we need to cautious and wait for the data to mature, as patient included in this trial was early T1, T2 lesions, node negative, where the follow-up should be long enough to derive any meaningful results. Next slide, please. ASTRO, next slide. ASTRO has issued guidelines for PMRT also. Means post-mastectomy radiotherapy. Next slide. Again, there were primarily 4 questions answered in these guidelines. Question number 1: is PMRT indicated in patient with T1, T2 tumors with 1 or 3 axillary lymph node positive who undergo axillary lymph node dissection? Question number 2 was: is PMRT indicated in the patient with T1, T2 tumors and a positive sentinel node biopsy patient who do not undergo completion axillary lymph node dissection. Third question was, is PMRT indicated in patient presenting with clinical stage 1 and 2 cancer who received a neoadjuvant chemotherapy? And question number 4 was, should regional nodal irradiation include internal mammary lymph nodes and or supraclavicular axillary apical nodes when PMRT is used in patient with T1, T2 tumors with 1 or 3 positive axillary lymph nodes? Next slide, please. PMRT in 1 to 3 nodes is long burning questions and has not yet been answered completely. We all know that. There are always arguments and counter arguments for using PMRT in such conditions. Older data including the recent update in of EBCTG are clear regarding the need for adding PMRT in such conditions. They have shown benefits in terms of loco-regional control and breast-specific mortality. However, the argument against PMRT, that is, age is that in the age of new surgical techniques and contemporary chemotherapies, the need of PMRT, especially when we all know that it on the left side it may increase the cardiac toxicity, is really worthwhile or not. However, we must keep in mind that radiation techniques have also improved, where we can control doses delivered to the heart, both by employing modern techniques and breath holding modalities, which are also available nowadays with us. Nonetheless, the clinical practice requires all the oncologists understand the risk adaptive approaches, where might be certain cases we don't benefit from PMRT. Next slide, please. So the panel recommendation, the panel anonymously agreed that the available evidence shows the PMRT reduces the risk of locoregional failure, any recurrence, and breast cancer-related mortality for patients with T1, T2 breast cancer and 1 to 3 lymph node positive. However, some subset of these patients are likely to have such a low risk of locoregional failure that absolute benefit of PMRT is overweighted by its potential toxicities. Next slide, please. Now, the question is again, the PMRT in clinical stage 1 and 2 those who have received NAC or neoadjuvant chemotherapy. So, in this, if axillary node persists after NACT for stage 1 and 2 and high risk factor for locoregional failure over there, then these kind of a patient should be irradiated. No, in fact, no randomized controlled trial is available, but there are a lot of series which are available which answer this question, and that is why the panel recommends that patient characteristics and disease profile is most important in answering this question. Next slide, please. Now we are waiting for this MRC Supremo trial to come up with their results. It is, in fact, it is a phase 3 trial which is waiting the results and data to get matured. Its primary endpoint is OS and secondary endpoint is DFS. It included patient with gray area profile, stage 2 with 1 to 3 lymph node positive or lymph node negative patients, but having high risk features. Here, patient with post NACT were also included. Next slide, please. Yeah. Even though we are waiting for the primary data and results to come out, they have come out with interim results on quality of life indices. It's 2 years follow-up and have showed that post-mastectomy radiotherapy led to more local symptoms up to 2 years post-randomization compared with no radiotherapy. Compared, patient did not get any radiotherapy. But the difference between these two groups was very small. What was interesting to note that the chest wall symptoms were highest when both radiation and chemotherapy were used. Next slide, please. ESTRO has come up with consensus guidelines on how to delineate target volume for early stage breast cancer. In fact, it's a vessel-based guidelines and have clearly mentioned regional nodal anatomy. Next slide, please. Next. Yes. Like intact breast, oh sorry, no, Abba, next, before, one slide before. No, before the, yes. Like intact breast, guidelines, ESTRO has also published consensus guidelines for tumor bed implant brachytherapy, the target delineation, and the doses. They have outlined the brachytherapy parameters and the instrumentation procedures and reporting measures as well. Next slide. Next. Yes. If you see the recently consensus guidelines have come up for target volume delineation in a setting of post-mastectomy radiation therapy. They have mentioned the area that need to be treated with higher chances of failure. There is no need to treat the entire volume, but only the skin flap area. However, cases with retropectoral implant positioning, either partially or completely, we need to alter our contours and include the post-implant space as well. Certain high-risk features like invasion of pec major or chest wall also warrants us to extend our contouring, over our contour, so that we can do this area and there are very less chances of missing these areas. With this, I would like to, stop my presentation here because I think otherwise it will go very long. Thank you very much. Thank you, Dr. Doval, for giving me this opportunity.